We now come to restoration options. When faced with a patient with missing tooth or teeth, it is important for us to know what are the treatment options available to rehabilitate the patient. Following this chapter, students should be able to explain all the prosthodontic options available for replacement of missing tooth and the fixed and removable options for dental implants. Each of the individual in this slide may need some form of prosthodontic intervention. What are your treatment options for these patients? The following slides will go through each of the treatment options available. One of the treatment options is to do nothing or to not restore the missing teeth. Doing nothing works well when the number of missing teeth are limited to the posteriors and the occlusion is stable. Unfavorable movement of the teeth is unlikely to occur, especially if it has not occurred within 5 years. When the disease is confined to the posterior teeth, it has been reported that a functional occlusion can be maintained following their removal with 20 occlusal units remaining. This is aimed at limiting restorative treatment for the elderly and overcomes any cost implication, disease risks, and other barriers associated with rehabilitation. The next treatment option is dental implants, and it is at the top of the hierarchy for prosthodontic treatment options. A dental implant provides support for a prosthesis and for a fixed type of prosthesis, and it does not rely on teeth or soft tissue. Thus, replacement of a missing tooth with an implant helps to conserve adjacent tooth structure as opposed to a fixed bridge that requires preparation of the teeth. When considering the treatment options, we also need to consider how long these restorations will be in the mouth without complications. Paspiridikos, in a systematic review in 2012, analyzed success at implant level, peri-implant soft tissue level, prosthetics level, and patient satisfaction level. It can be seen that when more parameters were included in the assessment, success rate drops and is reflective on the need for careful treatment planning. The next minimally invasive prosthodontic treatment option is the resin bonded bridge. This is because the restoration does not require extensive teeth preparation and retention is solely dependent on chemically adhesive luting resins. Rochette in 1973 introduced the use of a perforated casco retainer cemented with polymethyl methacrylate as a periodontal split and for tooth replacement. This option serves well as an interim restoration and is capable of good clinical service, with a median survival of 7 to 8 years for fixed design and 9 to 8 years for the cantilever design. Prior to implants and reliable bonding material and techniques, the fixed treatment option available for replacement of missing teeth is with fixed conventional dental bridge. However, the downside is extensive amount of tooth structure removal is required to produce the ideal retention and resistance formed in the bridge. With RBB and implants available as predictable restorative options, we may not have the mandate to prepare abutment teeth for a bridge, especially if they are virgin teeth. However, implants and RBB may not be the solution for all cases. The patient's systemic status, budget, preference, extensive edentulous span, and abutments requiring extracoronal protection may be a reason for it being the preferred choice. The projected 10-year survival of a conventional porcelain fused to metal fixed bridge is 89.2%, and for the porcelain fused to metal cantilever bridge is 80.3%. The 5-year survival rate for all ceramic fixed bridge is 94.3%, and the 5-year complication-free rate is 76.4%. The least preferred option by both clinician and patients is the removable partial denture, or RPD. It is most given to patients when anatomical, systemic condition, or distribution of missing teeth do not favor other modalities of treatment. For the clinicians, it is due to the biological burden of disease associated with this type of prostheses, due to the extent of coverage of the patient's teeth and tissues. For a patient having a removable prosthesis, it may be quite cumbersome or even embarrassing, as it has to be removed for cleaning and at night time to allow tissues to rest. Acrylic dentures are immediate, interim, or transitional dentures. They rely completely on tissue support and has more coverage compared to cobalt chromium denture. Metal-based appliances are usually to be preferred in terms of strength, less coverage, tissue health, and the ability to use more complex designs. The mean survival of an RPD is around 8.07 years, give or take around 0.66 years. Similar to conventional prosthodontic treatment options, implant prostheses may be both fixed or removable. For fixed restorations, it can be further classified as a crown, hybrid bridge, or fixed bridge, whereby the hybrid bridge resembles a denture and replaces missing soft tissue. For removable options, it may be either bar supported or stud retained, depending on the number of implants placed. The choice of treatment option would be depending on the number of missing teeth, patient's aesthetic needs such as provision of lip support, and also the restorative space available for restoration. This slide summarizes the advantages of removable type of implant prostheses according to Mish in his textbook Dental Implant Prosthetics. And the advantages of fixed implant prostheses are summarized in this slide. When a single tooth is missing, it is replaced with an implant crown. Depending on the angulation of the implant placed, the crown may be screw or cement retained. For a cement retained implant crown, a standard or custom abutment is screwed onto the implant, and this is followed with cementation of the crown. Screw retained crown may be cemented or casted onto an abutment, and the one-piece crown abutment complex is screwed onto the implant. Implant bridges are made to replace missing teeth. They may resemble just teeth or teeth and roots depending on the amount of tissue structure loss. Depending on the span or the arch and the number of the implants placed, as well as the angulation of the implants, the substructure of the prostheses may be casted or milled. Implant bridges may be screw retained when implants are well located surgically and placed in long axes that are parallel to one another. Otherwise, they are cement retained. A hybrid bridge includes soft tissue drape and is suitable when there has been a great amount of bone remodeling that has occurred following loss of teeth. The choice of material would depend on the amount of soft tissue to be replaced, taking into account the weight of the final prostheses, cost, and occlusal load of the patient. The table shows the estimated 5 to 10 year survival and 5-year success rates of implant-supported single crowns, implant-supported fixed dental prostheses, conventional fixed dental prostheses, and cantilever fixed dental prostheses. Although the survival rates for all types of prostheses are similar, when it comes to success, the conventional prostheses may perform better compared to implant prostheses due to the greater maintenance that may be required for implant prostheses. Let us move on to the removable type of implant prostheses. Most times, the decision of choosing a removable over a fixed implant prostheses is due to the greater number of implants required for fixed prostheses and its cost implication. The types of attachment for implant overdentures may be bar or stud types. Stud attachments have lower profile and require less restorative space compared to the bar type of attachment. This is an advantage when bone remodeling following complete edentalism is mild or moderate. The advantage of a bar type of attachment is that it offers more support to the prosthesis and takes away the support burden from the tissues. The survival of bar versus stud retained overdentures is summarized in this slide. It can be seen that the survival for both types is similar, and therefore the choice is governed by the patient's needs. Now that you are familiar with the treatment options, return to slide 4 and decide on the individual's treatment options. For further reading, please go through the literature in the list of references.